for us to start also looking at premenopausal women. There are a lot of premenopausal women who come with just the radius fractures. We didn't think much of it as far as underlying bone health. Now we're starting to get DEXAs on all those women and finding out that they have low bone mass, whether they're genetically predisposed or environmental reasons led them to that, nutrition, etc., which I'll explain in a minute. But also, if you look at that, if you have a wrist fracture before menopause, you're 2 times higher to have a hip fracture later in life. So it's also a signal to us. In men, we usually think of them as being really lucky in a lot of ways, and we've all come up against different ways in which men have an advantage over us. So in some ways they have an advantage with bone. They build stronger bones. As I said before, they can compensate better later in life. But they have up to a 30% chance of a lifetime fracture over 50. And they have equal risks at the same bone mineral density. So if you get a bone density scan and you have care with your husbands or your partners or whatever, if it's the same, they have the same fracture risk, no matter their gender. Also, really importantly, they're more likely to die after a hip fracture. Their mortality rate is significantly higher than women's after a hip fracture. For a variety of reasons we haven't totally sorted out. But that's a really profound thing that we're working on. They're more likely to become disabled, need long-term care, get placed instead of being able to live at home. And again, the ones who've had a wrist fracture have an increased risk for hip fracture. So we're looking again at the increased risk that one fracture tells us that you're going to have another fracture. And it's not just hip and vertebral fractures. Look, if you had an ankle fracture, knee fracture, all these things that we don't necessarily associate right now with osteoporosis, they all carry significant increased risk predicting that you'll have another fracture. And this is over baseline risks of someone who didn't have a fracture. So what that says to us as clinicians is we need to be able to prevent the next fracture. If the fracture is the first entry point for you to our system, our job is treat that fracture, keep you healthy through it, get you back to your prior level of function or better, but prevent the next fracture by treating the underlying condition. So we can change this. We can build stronger skeletons, we can prevent the first fracture and prevent the second fracture. So that's why I look at skeletal health across the lifespan, and I'm bringing my colleagues along with me. I came in to build a pediatric bone health program at UCSF, and I've now actually converted into doing it across the spectrum, so pediatric to geriatric. So the reason is this cartoon of a graph, even though it looks simple, is really powerful. If you look up this side and imagine going up on this axis is bone mineral density. The higher you go, the higher bone density you have, which infers a lot of strength to your bone. And across is just decades, 10, 20, 30, 40. Sorry, I don't have a pointer. Is there one that okay, if you don't mind me touching the screen like a 3-year-old. But what I want you to look at is if this curve along the top is your bone mineral density or bone mineral content. So in the first 10 years, you're on an upward slope. You're gaining bone. This window right in here around puberty, the 4 years around puberty, is a steep part of that curve. You're gaining lots of bone. And then you go up, and about by the time you're in your early 20s, you've hit your peak bone mass. So think about this with people coming behind you and how you might help affect that. By the time they're in their early 20s, they've gained as much bone. They're at the highest point of bone mass they'll ever be, which if you think of that as a bank account, you can understand that then if that's the highest paying job you've ever had, you're going to put a lot of that away, put as much away as you can and live off of it. So then as you go through your 30s and 40s, you're really kind of hanging on, and when you get to menopause, the 2 years near menopause, right after menopause is this precipitous drop in your bone mass. The difference between men and women I'll show you in just a minute, but then after that it slows down, but it's a continuous drop, and at some point you may get below what's considered the fracture threshold, so where your bones are much, much easier to break. So if you look at that, you can imagine that what would protect you the most is to get as high as you can earlier in life. Okay. So peak bone mass, as I said, most of it's gained by early 20s. There's a gradual loss over time. Women lose 30 to 50% of their bone density, their highest bone density, and men lose about 20 to 30%. There's another really important thing that we think by prediction models, if you can get 5% higher on your peak bone mass, it gives you 40% more protection against osteoporotic fractures later. So peak bone mass is a powerful point for us to aim for. And some factors that determine peak bone mass are modifiable and some aren't. So you've heard about a lot of these: activity, nutrition, estrogen, the hormone thing. There's also heredity, gender, ethnicity. I'll quickly point those out. And then we have added layers that we think about in healthcare, which are certain illnesses, medications, and malnutrition actually affect your bone in terrible ways. Looking at risk factors can't and can change, I'm going to stick first with the ones that we can't change, although in our town, gender is getting more fluid as to whether we can and can't change it, but looking at, typically men reach a higher peak bone mass and they don't have the precipitous drop that you see around menopause. So, and they're able to compensate better with that geometry that I told you about. So they have some protection in that way, but again, if they fracture, they're in worse trouble than we are. So the things, again, that you can't change, ethnicity, what we know now is Caucasians are at the highest risk, African Americans at the lowest risk for fracture, except for they don't make and convert and store vitamin D very well. So it's always these multivariate equations of what confers the risk. But in general, they have a lower fracture risk. Asians and Hispanics are between Caucasians and African Americans. And we'll skip that. Heredity is interesting because most of us think if the genetic component is whether your mother had a hip fracture is very predictive of whether you're going to need to really address your underlying bone health because you're genetically pre-programmed to have insufficiency. But it's also your body habitus. So you're predisposed in two ways to be at risk for fractures. Lean, older women have a higher risk of fracture than heavier. So the endomorph, ectomorph, your body type. So it's not just your bone is genetically programmed, but also your body habitus infers or provides protection or risk. Some of that's because fat helps convert and produce estrogen, and estrogen is protective of bone. We're not sure entirely how all of body mass plays into it. Interestingly, in kids, it's the opposite. The obese kids have more risk for fracture. I'll point that out in a minute. So let's go now to some things you can change, because that's our window of opportunity. But a real window of opportunity on the lifespan is what I consider these acquisition years, particularly the teen years, but all the way through the acquisition curve. Because the 4 years around puberty, you gain more bone than you'll lose in a lifetime. So if you look at that whole acquisition phase as the window of opportunity, it'll help you really understand why I'm emphasizing that and attaching it to the rest of the lifespan. So if you have osteoporosis, why it's important to think of osteoporosis as a pediatric disease is we can have a double whammy effect. We can prevent childhood fractures. We can also prevent adult fractures. It has a twofold effect if we can address it. So let's talk about nutrition briefly. Most people have heard calcium and vitamin D over and over. I won't go into that a lot, just a tiny bit. Vitamin A we don't hear much about. Too much vitamin A or too little vitamin A, both predispose risk to bone. Not enough protein, not enough calories, so if you see people who are doing restrictive eating, that's a big concern. Negative effects, sodium we don't talk much about, but too much salt leaches your bone. You've heard a lot about soft drinks. Sometimes it's just the fact that it displaces kids from drinking other things. So even the high fructose corn syrup drinks or anything but milk takes away from the amount of calcium they're getting. And caffeine has, if you're in 1 to 2 cups a day, it's not an effect, but tobacco certainly is. So we talk about how much, and I'm going to skip through a couple here because these numbers, as you know, keep changing. The amount of calcium, the amount of vitamin D that gets recommended keeps changing. But in childhood, basically, until they're about 4 to 8 years old, they're in that, 2 to 4 to 500 milligrams. If you think about one dairy serving as 300 milligrams, I usually tell the young kids to try to get 2 to 3 dairy servings a day. If kids are breastfed, they don't get vitamin D. It doesn't transfer in the breast milk. It's very important those kids get supplemented. Young kids who don't take in dairy, there are so many kids now saying I'm lactose intolerant. Whether they are or not, it's very important that they're getting the calcium they need. We always try to get kids to get this in food because milk proteins and a lot of other things we don't know about, including some things we know a little about, magnesium, zinc, things like that, they all infer good things on bone. So just taking a calcium tablet isn't the same as drinking milk or getting dairy. So we try to get in the diet first. If any of you work